Good afternoon all again. So we'll start with pathophysiology. We have seen the definition about what is traumatic brain injury. We have seen injury to the head. We have seen the normal physiology and anatomy. Now moving forward to pathophysiology, in which the first focal injury we have already discussed. Direct injury over a particular site will lead to the signs and symptoms. So damage can be in the form of hematoma, edema, contusion, laceration, or combination of all. Severe blow to the head leads to brain damage, leads to directly under the side of impact, but also to the side, other side, opposite side of the impact, which is also termed as hook counter hook mechanism of injury. So this is how, when specifically there is no headrest at that time, when the head is moving into deceleration, posterior aspect of the brain will be affected, and when the head is moving into posterior aspect, brain anterior aspect will be affected. That will come into the contact with the skull, and there will be injury. Diffuse axonal injury now coming, as we described, the axons directly, if they get damaged because of the trauma, it will lead to permanent loss of that part immediately. Yes, immediately there will be loss of the function of that part. So acceleration, deceleration, and rotational forces cause DAI, that is diffuse axonal injury. Widespread sharing and retraction of damaged axons. So widespread, if it is there, then it may even lead to coma. Yes, separation from the soma. Soma is nothing but the cytoplasm of the cells. Cortical white matter damage leads to directly coma. So just to picturize, you can see here the axons, they directly snap away. Yes, they are just like a rubber band. If they are stretched too much, they will snap away. There will be two different portions which cannot be reunited again ever. Sudden acceleration, deceleration forces cause such injuries. Also, the rotational forces, rotational injuries may happen. The injury is greatest where the density difference is basically at gray and white matter junction. Where the gray and white matter junction in the brain, they are meeting. At that portion, maximum chances of diffuse axonal injury happen. And if it is widespread, it will directly lead to coma. Third important pathophysiology, that is increased intracranial pressure resulting from swelling on hematomas. It leads to increase in intracranial pressure leading to herniation of brain parts, which is also termed as herniation. Hernia as a whole is a term used to describe improper positioning of the body part. Yes, may that be brain, may that be other body parts. Yes, so here herniation of body parts, that is moving the brain on one side or moving the brain from the normal position into some other position, which is also termed as conning. Hypoxia or ischemia, when blood vessels rupture or compress directly, injury na lidhe blood vessels rupture thase or compress thase, એના લીધે શું થશે, blood and oxygen will not be available to the brain, which will lead to and secondary impairments. Intracranial hemorrhages, which can be again subdivided into intracerebral, subdural, and extradural. Yes, intracerebral, within the cerebrum, within the mass of the cerebrum; subdural, below the dura mater; and extradural, above the dura mater. Yes, you already are aware of the three covering meninges. Yes, dura mater, pia mater, and arachnoid mater. All these three together can be termed as covering or meninges. So if the dura mater, if it is within the dura mater, that is in the cavity between the cerebrum and the dura mater, then it is subdural, and if it is outside the dura mater within any other cavity, that is extradural hemorrhage. Now severity of brain injury. This we talked about pathophysiology. Yes, now brain injury can again be divided into three sub portions: mild, moderate, and severe. Yes, mild means there will be mild symptoms, moderate will be okay, but severe will be prolonged symptoms that the patient may not even recover from coma. Yes, so severity, for that we are going to use one reference, that is Glasgow Coma Scale. Have you heard of the term Glasgow Coma Scale? Do you know what is Glasgow Coma Scale? Glasgow Coma Scale means what? Heard it or not? Yes or no? Can everyone reply in the chat? Do you heard of it? Yes, okay. is everyone aware about what is Glasgow Coma scale? Oh, components of Glasgow Coma scale, do you know? Okay, let me just. Okay. Okay, I'm so sorry. There was a call I had to take. Let me just present. Okay. So here is the components that we test. There are three main components highlighted in bold letters: eye response, motor response, and verbal response. Yes. Eye response you check for an individual. How do you check? શું કરવાનું check કરવા માટે? The first thing you see if they are opening their eyes spontaneously or not. When we ask them to do it, are they able to do it or not? Second, you check on verbal command. Yes, you ask them to do, they are not able to do. Third, you see if eye opening to pinch. So you will pinch the patient. And last, if they are not even responding, it at grade 1. After that, we see for motor response. Motor response, you tell him to make a fist, move any limb in a specific direction. If they are able to do it, it is normal, that is obey's command. If you are providing response, that is you are pinching the part and they withdraw that part and they locally withdraw that part, that means they are moving the part where you are pinching, that is they are localizing the pain and moving the part, that is grade 5. Grade 4, withdrawal from pain, general reaction to withdrawal, that is elbow ma tame, or you can say arm ma tame pinch karo છો and they are withdrawing that part, whole arm. Yes, so that is grade 4. If they are making flexion response, that is grade 3. Extension response એટલે કે તમે elbow માં sorry arm માં anterior aspect માં કરો છો pinch and they flex the whole arm. Yes, so that is grade 3. If they extend the whole arm and withdraw, that is grade 2, and no response is grade 1. Verbal response while talking. Yes, so are they oriented to time, place, person? Yes, higher cognitive functions that we have discussed. Are they confused or not? Do they use appropriate or inappropriate words? Incomprehensible sounds like ha, ho, yes, these are the sounds that are incomprehensible, which are not making any sense, that is grade 2. And no verbal response, not able to speak, is grade 1. So these are the responses. This is a total Glasgow Coma scale. Total score you can see 4, 5 and 6. So total is 15. Maximum score is 15. 15 is normal. If I tell you to open your eyes, you will be able to do, and you will be doing it spontaneously also without my command. Also, you will be doing motor response, that is you are obeying my command. Whenever I ask you to stand up, whenever I ask you to make a fist, you are able to do it. So your response will be 6. And verbal response, that is if I ask you to communicate with me, you are responding back to me, so that is also normal. So maximum score is 4 plus 6 plus 5, that is 15. 15 બોલો સ્ટુડન્ટ્સ આવ્યા છે 2 મિનિટ બેસવાનું. Yes, so total score is 15. So out of 15, if it is 15, it is normal. If it is minimum, what is possible is 3. Yes, not 0. Remember, Glasgow Coma scale is from 3 to 15, not 0. Always remember this. Okay, moving next. So using the Glasgow Coma scale, we will give the scoring of mild, moderate and severe. So when the physicians or a patient also neurophysician pass at that time, it will be needed that he or she should take Glasgow Coma scale as to diversify or distribute the patient into mild, moderate or severe category. So mild category, minimal damage to structure with slight or no permanent impairment. Characteristic, there will be headache, there will be poor memory that will not last long. Yes, this amnesia or poor memory will be temporary. It will get fixed with time. Dizziness, increased fatigability, irritability and decreased concentration power. So you can see higher mental functions specifically are affected. Memory is affected, fatigability, irritability, that is mood, and concentration is also affected. So attention will also be affected. Diagnosis, when can we say the patient is having mild symptoms? Loss of consciousness for less than 20 minutes. Yes, injury thigh, ena pachi 20 minutes maximum the patient is unconscious, then the consciousness level becomes normal. Glasgow Coma scale more than 13. If the Glasgow Coma scale is more than 13, 13 to 15 is normal. Yes, so if it is 13 to 15, it is considered mild type of brain injury. No focal neurological findings, no abnormality on CT scan, and discharge from hospital within 48 hours. Okay, so sorry, I'm having multiple. So loss of consciousness for less than 20 minutes, Glasgow Coma more than 13, so 13, 14 or 15, that is considered mild. No focal neurological findings. Yes, MRI कराविए, MRI will be normal. Specific कोई एक region affected नहीं होए, and no abnormality on CT scan. Discharge from hospital within 48 hours. Our diagnostic criteria is patient, and then only we can say it is mild type of. Second, moderate. So moderate is between 8 to 13. Yes, Glasgow Coma scale, GCS. You will, when you are going to hospitals or when you are going to visit clinics, at that time when you read the file, this acronym will be used, that is GCS, Glasgow Coma scale. It defines what is the normal value, 8 to 13 for moderate brain injury. And for severe, it will be less than 8 or even less than 5. Severe, for diagnosis, we see severe enough to cause obvious disabling deficit. Persistent vegetative state occurs in small percentage of patients. Persistent vegetative state is state of, you can say, continuous confusion, and the patient is not oriented completely. That is persistent vegetative state. We are going to see the levels of consciousness in traumatic brain injury itself. Because the injury is so severe, does not allow restoration of consciousness. So completely the patient cannot become conscious. Ekdam normal conscious like you are right now. You may even be sleepy at a point, but still you are conscious. Yes. So this is again persistent vegetative state, abnormal consciousness level. Patient unaware of surrounding environment. Patient does not know what is going in the surroundings. So orientation will be lowest. Cannot speak, cannot communicate, no voluntary function, completely paralyzed, and may persist for years. The patient may even be in coma, and that state may even last for various years. So that is termed as severe brain injury. Diagnosis is based on two specific conditions commonly available and some advanced techniques, like we are going to see PET scan or functional MRI. They are widely adaptable or available. First, CT scan, X-ray and MRI. These are readily available, but these hospitals may easily and that can be helpful to diagnose the patient with such conditions. Yes, traumatic brain injury, CT scan, MRI and X-ray. Some technologically advanced but less readily available, not available everywhere in multi-speciality hospitals. These things may be available, otherwise we cannot see. So PET scan, that is positron emission tomography, single photon emission computerized tomography, and functional MRI. Yes, so these are some diagnostic tools that a neurophysician will use for diagnosis of this condition. Same as we are also going to use the same things for stroke also. Yes, but here there are chances the patient will give you a history of trauma. That is the only difference between stroke and the traumatic brain injury. Something that is external and other thing. In stroke, it is internal. That is related to blood supply of the brain. Coming to clinical picture. Yes, so the first and foremost sign or the warning sign after the trauma will be confusion, loss of consciousness, inability to speak, inability to talk, inability to communicate as a whole. Yes, so those will be the first sign. Dizziness. After once the trauma is happened, cognition will be affected first. Yes, cognition, which involves the late state of consciousness, orientation, memory deficit, impaired attention, impaired self-awareness. Patient will not even be aware how to walk safely, how to follow normal safety procedures. The patient will not know. We are not talking about any important or out of the way safety measures. We are talking about our own body measures. Yes, if I am seeing a chair is placed in my way, what will I do? I will either move the chair on a side or I will move from the side of the chair. Yes, I will not walk through the chair. So this is also normal safety awareness of an individual that is lost because cognition is affected. Impaired executive functions overall, problem solving functions, and locked in syndrome. Locked in syndrome we had discussed in stroke also. Can anyone tell me what is locked in syndrome? I have given you an example also. What is locked in syndrome? Yes, tell me. What do you know? You are free to tell me. What is locked in syndrome? Does anyone remember? I had given you an example from a movie, if you can recollect. It was from the movie Munna Bhai MBBS. Yes, the Anand Bhai. He was having locked in syndrome. That means he was able to see everything, he was able to hear everything, but he was not able to cognitively reply to that. There is no motor response. Yes, so that is locked in syndrome. So that is also one of the possibilities that the patient will be having after traumatic brain injury. Neuromuscular impairments, same as stroke that we have discussed, abnormal tone, sensory impairment, motor impairments, visual and perceptual impairments, swallowing impairments, behavioral impairments, communication impairments, indirect impairments. Majority of this we have discussed in stroke, same things will be applied because no matter the cause is different, the sequel or because of that the symptoms will be very similar. Altered state, altered state of consciousness. So confusion, comma, stupor, obscurity, delirium, clouding of consciousness, and persistent vegetative state. These are the levels of consciousness. The first being a cause, and others are all the levels of consciousness, different levels of consciousness. Yes, we'll keep it till here. I'll be discussing with you altered state of consciousness in the next lecture. I have some important work to do. So we'll complete this in the next lecture and we will go forward for other signs and symptoms and directly to the main management of traumatic brain injuries. Yes, any doubts till now? Please let me know. Yes or no? Everyone should reply in the chat. Okay, fine. Have you taken the attendance, Purva?
Yes, sir.
Okay, so we'll keep it till here. I know this lecture was very brief, but the next lecture I'll try to extend more and we'll complete as much as possible traumatic brain injury. Yes, okay. Fine. Hope you have a good day. Be safe.
Thank you, sir.
Thank you, sir.